Hi, my name is Preeti, and today I'm going to be talking to you about AI in employer-sponsored insurance. Before we dive in, let's start with a deployment challenge, one that you're all likely familiar with, and one that plays out every single day in one of the largest and most complex healthcare ecosystems in the world, here in the United States. So here is the problem. You have about 160 million patients, and they're geographically distributed across every single zip code in the country. Their data lives in dozens of incompatible electronic health record systems, claims databases, pharmacy records, wearable devices, and so on. Their care is delivered by thousands of providers working in silos and operating independently. And the entity responsible for their coverage is their employer, who has limited visibility into what's actually happening clinically once the claims have been submitted. Now, the challenge for you is to build an AI system that improves the outcomes for all of these 160 million Americans, regardless of who they are, regardless of where they are located. That is the challenge of AI and employer-sponsored insurance. I work at Morgan Health at the intersection of clinical AI and employer-sponsored healthcare. What that means is that I spend a lot of time thinking about what it means to deploy AI in real-world settings, what it means to integrate AI into clinical workflows, how to build trust in AI, how to make sure that providers actually use it, how to make sure that explainability is something that is not an afterthought, but baked into the system from the get-go. And I want to talk to you about all of these questions today. I'll also walk you through 5 specific examples of AI that are being used by companies in production today, along with a deep dive into what those companies are actually doing. And yeah, I want to ground you in real work. So without further ado, let's start with the scale of the problem. Let's look at the numbers, because the numbers are truly staggering. $1 trillion. I want you to remember the number. That's what American employers collectively spend on healthcare for their employees every single year. And it covers an enormous population of 160 million Americans who get their health insurance through their workplace. Now, you'd expect that with this level of investment, we'd be seeing world-class outcomes. But that's not what the data shows, sadly. Despite the annual spending, outcomes have remained stubbornly stagnant. In many categories, they've actually gotten worse. Morgan Health conducted research last year that found mental health burdens have worsened over time, with notable gaps in treatment for underserved populations. Racial disparities in maternal health persist, and the list goes on. What makes this truly unsustainable is that the costs aren't just high, they're accelerating. If you look at the graph on the screen, national health expenditure in the United States has grown to 5.3 trillion annually and has grown at an average annual rate of roughly 5% over the past decade. For ESI, the average employer is now experiencing double-digit year-over-year increases in their health benefit costs. If your healthcare costs are growing at 10% annually, they double every 7 years. That's not a sustainable trajectory for any organization. Cost challenges for payers are also trickling down to people. Best Health Gallup's latest affordability report found that an alarming 1/3 of Americans are making significant financial, medical, and personal sacrifice due to healthcare costs. All these challenges, double-digit cost increases, fragmented care experiences, and significant variation in access and outcomes, creates a significant opportunity for AI in ESI. We at Morgan Health believe that AI-driven clinical solutions can improve the quality, affordability, and equity of employer-sponsored healthcare. When we talk about quality in this context, we're talking about clinical outcomes. Are employees actually getting better? Today, the answer is inconsistent at best. AI, however, changes this equation. Clinical decision support tools can analyze a patient's full history, cross-reference their latest medical literature, and recommend treatment protocols that are both evidence-based and personalized. Computer vision can catch things in imaging that the human eye might miss. The result is care that's smarter, more precise, and more likely to work the first time. The second pillar here is affordability, and this is where the cost conversation comes back. A significant share of healthcare spending is waste in the form of unnecessary procedures, duplicative tests, and preventable hospitalizations. AI attacks waste at multiple points in the care journey. Triage systems can route patients to the right level of care immediately. So an urgent case gets seen urgently, and a routine issue doesn't consume emergency resources. Now, isn't just an allocating problem. It's about allocating resources intelligently so that every dollar is actually driving an improved healthcare outcome. And the third pillar, and I argue that this is the most important one in the long run for us, it's equity. Access to healthcare varies by geography, by socioeconomic status, and by 100 other factors that have nothing to do with the quality of your plan design. AI can actually help close these gaps. It can personalize outreach so that a wellness program actually reaches the people who need it most, not just the people who are most engaged. It can identify disparities in care delivery that would be invisible in aggregate, but become clear when you get a model to take a closer look at it. Ultimately, quality, affordability, and equity, these aren't separate initiatives. They're three dimensions of the same transformation, and AI can move the needle on all three of these simultaneously. So better care doesn't have to cost more efficient care doesn't have to mean less personalized care, and more equitable care doesn't have to be a trade-off against anything else. But we've been hearing about AI for a long time. Why is this moment different from the last decade of AI promises? So if AI has been the future of healthcare for the better part of the last decade, why should we believe that this time it's different? It's a fair question. I've sat in rooms like this one where the promise of AI was always just around the corner, always one more breakthrough away from the real impact. And the honest answer is that for a long time, the conditions, the infrastructure, the models just weren't there. But something has shifted. And I want to spend a few minutes talking about that. One of these is data maturity, or data availability, rather. Even though there's room for data infrastructure to mature, employers and health plans are now sitting on hundreds of millions of medical and pharmaceutical claim records. This is real clinical and administrative data of real patients working through the real system. That's new and something that wasn't there before. The second force, perhaps the most discussed in the news today, is model capability. This is where in the last few years there's been genuine transformations. For example, generative AI, large language models, computer visions, advanced NLP. These are household names now. These are household terms. They're no longer research curiosities. They're production grade tools that can be deployed across complex healthcare workflows. And finally, market pressure. Frankly, I think this one turns possibility into action. With rising costs, AI has moved from the innovation line item to the strategic imperative line item. It's no longer a nice to have. For many employers, it's becoming a competitive necessity. Now, any one of these forces by themselves would be very interesting. But now that we have all of the forces at the same time, that's the window we're in right now, which is truly transformative. So, what does this look like in practice? I want to walk you through 5 specific applications of AI in employer-sponsored healthcare. Looking across these 5 use cases, you will see a few technical themes that will emerge consistently. First, companies doing the most interesting work are the ones who've invested most heavily in data infrastructure, not just AI or model infrastructure, but actually the data infrastructure that fuels it all. Second, the best model in the world has zero clinical impact if it's not integrated into the workflow where clinical decisions are actually made. Third, black box outputs are not acceptable in this environment, not for regulatory reasons, not for liability reasons, but because clinicians just won't use your models if they cannot understand the results. And finally, closing the feedback loop between prediction and outcome is what separates a research prototype from a production system that actually improves care. With that, let's delve into our first use case. Let's start with clinical decision support. And I want to frame this as a technical problem first before we get to the solutions. A clinician making a treatment decision is taking a set of inputs, so your patient history, presenting symptoms, lab values, your interactions, imaging results, and mapping them to a treatment recommendation from a very large and constantly evolving hypothesis space. The challenge is that the hypothesis space, the body of available medical literature and outcomes data, is growing faster than any one individual clinician can keep track of. It's a fundamental information processing limitation, and it's exactly the kind of problem where AI can help. And Bold Health is operationalizing this in a particularly interesting way. Their virtual assistant doesn't just generate treatment recommendations, it also solves the provider selection problem. So even if you know the right treatment protocol, you need to connect the patient to the provider who consistently delivers that protocol at high quality. From an employer perspective, the impact is measurable. fewer unnecessary procedures, better first time outcomes, and reduced variation in care quality across the employee population. So, a win for all. The second use case here is patient triage. And triage here is a broader problem than just the emergency room triage that most people think of. Triage is fundamentally a routing and prioritization problem. So you have a population of patients presenting with varying levels of complexity across multiple care settings. So primary care, urgent care, emergency departments, telehealth, specialist referrals, what have you. The system needs to assess the criticality of each presentation in real time and route the patient to the appropriate care setting and provider. Get it wrong in one direction, and you have an urgent case waiting for days for a primary care appointment with worsening symptoms. Get it wrong in the other directions, and you have a routine issue consuming expensive and scarce emergency resources. This is a multi-class classification problem with a significant class imbalance, real-time latency requirements, and asymmetric error costs. A false negative, missing a high complexity case, has a very different cost than a false positive. The asymmetry has to be built into the loss function. Cortica is one such organization leveraging AI systems for triage. They are a leader in autism and neurodivergent care, and they leverage AI systems to speed up their initial diagnosis process and reduce delays in treatment, which remains a key hurdle for patients and families today. For employers, the impact is faster access to care, reduced emergency utilization, and meaningfully better outcomes for employers and their families navigating neurodivergent diagnosis. What we can also learn from this Cortica example is that domain-specific training data really matters. A general purpose triage model trained on adult emergency department data will not generalize to pediatric neurodevelopment presentations. Domain specificity isn't a limitation, it's a feature that we should all take into consideration when designing our models. The third use case is precision diagnosis, specifically the application of computer vision to medical imaging. This is probably the most technically mature of the 5 use cases that we are covering today. And it's the one where the ML community has made the most measurable progress over the past decade. The core technical problem is object detection, its segmentation, and highly dimensional, high noise image data. Medical images, X-rays, MRIs, CT scans are fundamentally different from the natural images that most computer vision benchmark datasets have. So they're grayscale or low contrast. The features of interest are often subtle, a 2 nodule, or a slight asymmetry. The radiologist shortage makes this problem even more urgent. The US is projected to face a shortage of 42,000 radiologists by 2033, according to the Association of American Medical Colleges. Meredith's Merge Imaging Suite is a production deployment of these principles at scale. Meredith has one of the largest medical imaging datasets in the world, which gives their models a significant training data advantage. They're also tackling the multimodality challenge, building models that can synthesize findings across the same patient's X-rays, CT, MRI, and ultrasounds, rather than treating each modality as an independent classification problem. The impact is earlier detection of serious conditions, fewer diagnostic errors, and patients on the right treatment path sooner. But the technical takeaway is about the deployment architectural challenge. Specifically, how do you integrate AI into existing workflows in a way that actually changes behavior and drives adoption of the systems? The fourth use case is risk prediction. And this is where the employer-sponsored healthcare dataset really shines from a machine learning perspective. This is the use case that directly leverages the claims data infrastructure that we talked about earlier. This is fundamentally a time series prediction problem on longitudinal claims data. And it's harder than it sounds because the signal you're looking for is often subtle, as is the case with a lot of these use cases. Distributed across multiple data sources and buried in a data sets with significant class imbalance. High-cost health events are by definition rare, making this even harder. Building a model that can identify these events early without generating an unmanageable volume of false positive is a genuine technical challenge. One organization, ApriHealth, has built a platform that analyzes 220 million medical and pharmaceutical claims, a data set that gives their models a training and validation advantage that is very difficult for smaller organizations to replicate. And the insights that they produce can be leveraged at scale. For employers, the impact is reduced hospitalizations, better chronic disease management, and lower catastrophic claims. But the technical takeaway for us in this room here today is about the importance of closing the loop between prediction and intervention. and the challenge of building models that are not just accurate in aggregate, but fair and well calibrated across demographic subgroups. This is especially critical when you're trying to use these types of data for population health management. The fifth and the final use case is personalized treatment. And I've saved this one for last because I think it represents a relatively new frontier for us. The core technical problem is treatment response prediction and care pathway optimization for individual patients. The goal is to move beyond population level treatment protocols, which are derived from randomized control trials, which is the gold standard today, to patient specific recommendations that account for individual variations in genetics, comorbidities, treatment history, real time clinical status. One of the organizations that Morgan Health has invested in, Time Care, is deploying these capabilities in value based oncology, one of the most complex and high stakes care environments in healthcare at large. Cancer care is the ideal use case for personalized AI because the treatment decision space is enormous. The consequence of suboptimal decisions are severe. And C, the patient experience is notoriously fragmented. TimeCare's platform uses AI to guide patients through their entire cancer journey, from initial diagnosis through treatment planning, ongoing monitoring, and survivorship care, personalized to their care journey. For employers, the impact is higher engagement with care plans, better outcomes for complex conditions, reduced care fragmentation, and improved overall employee satisfaction. The technical takeaway is about the frontier challenges of personalized medicine: causal inference from observational data, multitask learning for complex outcome prediction, and NLP driven clinical trial matching. So, a lot of opportunity exists in this space. So, with that, we've covered the 5 use cases of AI making real change in ESI today. Bringing this all together, I want to take a moment before we close to make the transformation concrete. We've covered a lot of ground today on how AI can move the needle on improving outcomes for a large population of the United States. Every item on the right side, which we describe here as the future state, is technically achievable today. The model exists, the data infrastructure is maturing, the deployment patterns are being established. Closing the gap between the current left column and where we want to go, which is the right side of this slide, is the work ahead of all of us in this room today. And it starts with the decisions that we make next about how we build these systems, what data we train these systems on, what evaluation frameworks we use, what explainability standards we hold our vendors accountable to, what monitoring pipelines we build, all of it, what it means to make a model actually work in the real world, in real clinical settings. But most importantly, all of us in this room also bear the responsibility of ensuring these models are not just deployed in the real world settings, but they're deployed in a way that actually work for the patients that they're actually meant to serve and designed to help. I will leave you with that thought. Thank you.